Hello friends, welcome to Physiopedia. So today we are going to study about osteoarthritis. It is a term that is arthritis, which means joint plus means joint and itis means inflammation. So it is basically an inflammation of the joint which is caused by some degenerative changes. Okay, so arthritis is classified into three parts: osteoarthritis, rheumatoid arthritis, and another is metabolic arthritis. So today we are going to study about osteoarthritis. So basically it is a degenerative joint disease as we have seen in a figure. Okay, so it is classified into two categories: idiopathic or primary, and another is secondary. So primary is due to nature that causes naturally in older age or due to weight bearing. It has no another underlying cause and with a non cause. Okay, and secondary osteoarthritis is caused due to some infection like osteomyelitis, etc., or any type of trauma to that joint, or another can be of any type of fracture, obesity, excessive weight, etc. Okay, so post traumatic arthritis in knee is also common. Okay, so these are the common sites which are usually involved in osteoarthritis: distal interphalangeal joint, proximal interphalangeal joint, and carpometacarpal joint of thumb. Okay, another is cervical and lumbar spine, hip joint, knee joint, and first MTP. So hip and knee joint are most common in our country. So we start with the clinical features. First, you should know about the pathology of the osteoarthritis. So basically it is a degenerative condition, so it primarily affects the articular cartilage of that particular joint. So first, primarily there is affection to the articular cartilage. It gets rubbed due to repeated weight bearing on it, so it causes fibrillation to the cartilage, and with further rubbing there is subchondral bone becomes hard and glossy, so it gets hypertrophied and forms margin and projecting spurs, which is known as osteophytes. Osteophytes are the main clinical sign on X-ray, and there is also formation of subchondral cyst and sclerosis. So after the it gets more degenerated, the synovial inflammation is present, and that causes the deformity and stiffness to the joint. So for example, in knee joint, medial compartment gets very much weight bearing than lateral side. So medial side affection of osteoarthritis are more common. Okay, so now let's continue with the clinical features. So first and foremost symptom of the osteoarthritis is pain. Every patient of the osteoarthritis will present with the complaint of pain initially. So there will be less or intermittent pain initially. It only appears as the patient does some activities or ordinary activities like running, walking, etc. But as the degeneration increases, it continues even at rest. So pain gets worse and it will feel like a cramp. Okay, so there will be geographic variation in osteoarthritic patient. Like in western countries there are more cases of hip osteoarthritis, but in India, like in Asian countries, there are more cases of knee osteoarthritis due to like cross sitting or squatting position are more common in our country. So okay, another is swelling. As I understand, as I teach you in pathology, there will be swelling, so that will restrict the range of motion. So swelling will be present, yes, and stiffness will also be there in later cases. And in in early morning, initially stiffness will be more present due to muscle pain and spasm. And another is deformity in later stages, like Januvarum or board legs deformity is more common in knee osteoarthritis cases. So on examination, as we have to prepare a presentation or uh, demograph or any type of assessment, there will be need of this. Okay, so on examination we will see the swelling, muscle wasting will be present, movements are painful and restricted, and crepitus felt on the joint movement. Crepitus will also be the clinical features mainly, and loose body in the joint in later stages. Okay, then we will start with the osteoarthritis of the knee, which is most common. So knee appears to be more prone to arthritis, which due to these factors. Okay, so meniscal injuries, fracture in the joint surface of tibia or femur, fracture of tibia or femur producing biochemical mechanical changes in lower extremity. In short, due to obesity or another, as we know, knee joint is more prone to weight bearing compared to all joints of our body. So there are more chances to get injury in the knee joint. So it will be always more prone to get osteoarthritis due to also these predisposing factors. Then we will find the subjective findings, which is onset, as I earlier told you that it starts gradually with no cause or possibly due to previous trauma, or if it is secondary. Okay, and duration, then it will get increased over period of time, like months or years, it will always get increased. Okay, then frequency, long ongoing episode with exacerbation and reemission of symptoms, usually associated with increase and decreased in weight bearing activities. Okay, so if the patient is not weight bearing, then it will be relaxed to the knee joint, so there will be no weight bearing that will relieve the pain. So frequency will be according to that. And another is area of symptoms around the knee joint, medial, as I earlier told you, primarily medial compartment is more affected. Okay, then type of symptoms, there will be dull aching pain or cramp like pain. Stiffness and deformity may also be present in long cases. Okay, and now we are going to study about objective findings. On observation, we will find that swelling will be present over the knee and mainly over the medial aspect of the knee joint. Deformity may also present, like I earlier told you. Fixed flex deformity may also be present, and another board legs and or Januvarum. Okay, then movements like both flexion and extension both are limited, and crepitus may be felt during these movements. Okay, then on palpation, tenderness obviously must be present as the patient is coming with the complaint of pain. So okay, then which are the common impairments in knee osteoarthritis? So those are with joint involvement, pattern of restriction at the knee joint is usually more loss of flexion than extension. So as there is the osteoarthritis, there will be weakness of the quadriceps muscle. So there will be weakness in or more loss of range of knee flexion than in extension. Okay, so in resting, the joint assumes 25-degree flexion, which will cause the fixed flex deformity, and little motion is possible because of swelling. So symptoms of joints such as distension, stiffness and pain and reflex quadriceps inhibition may cause extension leg. Now what is extension leg? Extensor leg, it is an active restriction of the knee flexion, like patient will unable there will be active uh, restriction of knee extension. There will be there will be active restriction of knee extension. The patient will unable to extend his knee properly. The knee will stay in some degree of flexion, that is termed as extension leg, which can be resolved with stretching or any type of physiotherapy. Okay, so that will also be present, or it can also turn into fixed flexion deformity, which cannot be resolved. Another is disturbed balance response, also have been reported in patient with arthritis. If the patient is having osteoarthritis bilateralis, then he will get disturbance in balance. Okay, now common functional limitation or disability. So which are the activities that will be limited in the patient of osteoarthritis are written as here. So with acute symptoms and in advanced stages of degeneration, there will be pain during motion. The patient will be unable to move or bear weight, or there will be a disturbance in gait, or he cannot perform his routine household activities or community activities. Okay, there will be limitation of difficult controlling weight bearing activities. Okay, that specifically the activities which enhance knee extension will also very limited, like walking, running, climbing, stepping up, stepping down, raising from a chair, stooping forward, etc. Okay, another in with end stage of osteoarthritis, physical activity is markedly curtailed with less participation in leisure activities, like patient in end stage, there when there is severe degeneration, patient will be patient will be unable to walk, garden, swim, like another household activities will also be limited. So now here our roles present. Physiotherapy management. So these are the goals that we set for the patient of osteoarthritis of knee. So first we have to educate the patient that what is it about, what is the treatment of it, and what type of care should be taken. Okay, second is decreased effects of stiffness. We have to enhance the activities that will overcome the stiffness, like hip knee extension is very much limited, so we have to enhance those activities which will enhance knee extension. There will be decreased pain from mechanical stress and prevent deforming force. Okay, so first treatment goal should be decrease the pain. Patient will always present with us with the complaint of pain, so first we have to limit the pain, and then we have to increase range of motion, improve neuromuscular control and strength and muscle endurance. So then we can start muscle strengthening activities. Then we can improve balance and improve physical conditioning. Okay, so teach about the deforming force and prevention. Teach home exercise program to reinforce intervention and minimize symptoms. Another active range of motion and joint play mobilization techniques, which I hope you already know. Active range of motion of the knee, like knee flexion, extension, medial and lateral rotation, must be performed, and some knee mobilization should be given. Another splinting or assisted equipment to minimize the stress or to correct faulty biomechanics. So we can give splint that will enhance knee extension. So during a day, some of us will provide knee extension that will improve the extensor leg. So yeah, now strengthen supporting muscles and alternate activity with periods of rest. Rest is also important. Okay, then stretch muscles, joint or soft tissue restriction with specific techniques. So we can give stretching and another techniques like hold and relax, contract and relax, and other PNF techniques can be performed. Another low intensity resistance exercise and muscle repetition. And as the patient gets this control, then balance training activities should also be initiated. Non-impact or low impact aerobic exercise, like we have to improve that cardiac status, so aerobic exercise must be initiated, like low grade treadmill walking can be initiated. So yeah, now management. First we have to control the pain and protect the joint. So we have to educate the patient, we have to give home advice, ergonomic advice. Another functional adaptation, like patient have a habit of putting a roll below the knee, so we have to prevent it because it can cause fixed flexion deformity. So yeah, and another modalities like TANS, IFT that will relieve the pain, and distraction techniques can also be given. Second goal was to maintain soft tissue and joint mobility. For that we will perform active and active assisted or active range of motion. Okay, then maintain muscle function and prevent patellar adhesion. Educate the patient, decrease pain from mechanical stress. Patellar tapping can also be performed. Increase joint play and range of motion. We will enhance this activity by joint mobilization and patellar mobility activity. Improve muscle performance in supporting muscles, progressive strengthening and muscle endurance. For that we can do isometrics and hold and relax and another techniques that will increase the muscle strength of mainly the quadriceps muscle. So VMO strengthening, that is vastus medialis oblique muscle strengthening. So in this exercise we have to put a roll or a pillow below the both the knees, and that will provide partial knee flexion. Then patient is asked to extend his knee and hold it for 10 seconds. Another is quadriceps strengthening, that is patient is standing and therapist will give resistance by the TheraBand and will assist and patient is asked to extend his knee against resistance, that will strengthen the quadriceps muscle. Another functional training can be provided by step up and step down activities. As the patient gets control in knee extension, we can start these activities. So yeah, forward, backward and lateral step up, step down exercise can be initiated. Wall slides and mini squats to 90 degree if tolerated, that is partial squats with the support of wall. Then partial lunges and balance activities can also be initiated. To improve cardiopulmonary endurance, swimming, bicycle, aquatic exercise can also be initiated, and home advice must be given in the case of osteoarthritis of knee, like weight bearing activities should be reduced. Patient should walk with some walking aid like stick or walker. Then prolonged standing, cross-legged sitting, stair climbing, squatting, kneeling should be avoided, must be avoided to prevent further degeneration. Then if the patient is obese, then he should be requested to reduce his weight. That will help to prevent the damage. And as I already told you, use some assistive device like stick and can. So yeah, thank you so much, and you know the drill. Like, share and subscribe. Bye bye.